Hello, and thank you for joining the National Clinician Consultation Center's Clinical Technical Assistance Office Hours. My name is Brenda Goldhammer, and I'm the Program Director of the NCCC. Today's interactive panel discussion will be about aging, substance use, and cognitive health. Before we begin, I have a few housekeeping items. First, we kindly ask that you please mute yourself. We're happy to unmute you if you have a question for our panel. Also, on the bottom of your screen, there is an option for Q&A for you to submit any questions you have for our presenters today. We would love to know what you think about today's webinar, so please be sure and fill out our evaluation at the conclusion of our discussion. Our panel today includes Drs. Christy Soren, Anna Chodos, and Triveni DeFries. Dr. Soren is a Deputy Medical Director for Substance Use Services for the San Francisco Department of Public Health. Prior to this role, Dr. Soren was a medical educator and primary care physician at UCSF and the medical director at the UCSF Outpatient Buprenorphine Induction Clinic. Dr. Anna Chodos is an associate professor of clinical medicine at UCSF in the Division of Geriatrics and the Division of General Internal Medicine. She's the medical director of outpatient geriatrics at Zuckerberg San Francisco General Hospital. Dr. Triveni DeFries is an assistant clinical professor of internal medicine at UCSF, where she also completed a fellowship in primary care addiction medicine. She's a clinician educator and addiction medicine physician at Zuckerberg San Francisco General Hospital's General Adult Medicine Primary Care Clinic and attends on the hospital's inpatient addiction medicine consult service. She also works as a clinician consultant for the NCCC's Substance Use Warm Line since 2019. If you are a healthcare provider and you have questions that we are unable to get to today, please consider calling us on our substance use warm line, where you can speak with Dr. Fries along with our other clinician consultants. Our webinar and the substance use warm line are supported by the Health Resources and Services Administration's Bureau of Primary Healthcare. Before I turn over our webinar to our esteemed panel, I want to first introduce Laura Chassow to tell us more about HRSA BIPIC.
Hi, thank you so much, Brenda, and I am really excited for this panel. I work for the Bureau of Primary Healthcare in our Office of Quality Improvement, and we are committed to providing training, technical assistance to help our health centers really do the work that you guys do, because it's so important, and we want to be able to support you in that. And working with NCCC has been a great way, and both with webinars like this, addressing subjects that are really important but often don't get enough attention, as well as with the warm line and their other lines for when you as clinicians need additional help. Next slide, please. I want to let everyone know about a really great opportunity we have for our health centers, which is the Quality Improvement Fund Transitions in Care for Justice-Involved Populations. This grant, these applications are due on June 10th, and it's a really brand new opportunity to, due to policy changes, work with incarcerated populations while they are still incarcerated to make sure that their transition to care is uninterrupted. And we are looking for innovative approaches and health centers to really take charge in this. And SUD services are a huge part of the area where the interruption in care is really can be quite deadly, and we'd love to have you all apply for it. And now I'll hand it back to Brenda for this great presentation. Thanks.
Doctor, do you want to go ahead and take it away?
Okay, sounds great. I hope everybody can hear me and see the slides. The three of us will go ahead and get started now on our talk about aging, substance use, and cognitive health. We have no financial disclosures. And by the end of this webinar, we hope that you'll be able to identify the impact of substance use on older adults with cognitive impairment, incorporate a workup for substance use for an older adult with cognitive impairment, and adapt a substance use disorder treatment plan for them. We'll start by talking a little bit about epidemiology, and then we'll move into a section on assessment, followed by a section on management. We are not going to talk for very long. Actually, our intention today is to leave a lot of open time for questions, and the three of us are here really to organically answer questions that come up and really act as a panel for you. I'll go ahead and get us started here with epidemiology for some background to help us understand the problem that we'll be discussing today. So, why is it important to assess for unhealthy substance use among people with cognitive disorders? Well, a lot of what we know about this actually comes from data just in general about older adults in the US. And we now have the largest group of older people in the history of the United States. And as they age, more presentations and complications of substance use are seen. Maybe you're seeing them in your clinical practice now. And we know that substance use disorder is on the rise in this rapidly aging population, and it's projected to increase. And this might be due to several different factors, including the aging of the baby boomer generation, who had changing attitudes towards substance use. And then those who were more likely to have used substances when they were younger continue it into later life. And as people age, they're more likely to experience negative effects of drugs and alcohol from the comorbidities that they may have developed or from interacting medications. And most people, though, over 65, they don't use illicit drugs, but 20% of older adults misuse alcohol, over-the-counter medications, and prescription medications, and that's often unintentional. And lastly, for older adults, this makes a difference because data does show that the harms of substance use are on the rise in the form of hospital admissions, and as this graph shows here, in overdose rates. And we know that substance use impacts people from all backgrounds, but we see the harms disproportionately affect people of color and people from minoritized backgrounds. I'll hand it over to Dr. Soren to talk a little bit specifically about the impact of drugs and alcohol on the brain.
Thank you so much. So we know in the acute setting, when someone has just used a substance, whether it's alcohol or an other unprescribed substance, that it can impact judgment. When someone is intoxicated, it can impair memory and attention, and people can act disinhibited. And if this continues to go on, where someone continues to use a substance over time, the brain adapts. And it adapts by changing metabolism in different parts of the brain. It regulates blood flow. There can be receptor downregulation and upregulation, changes in neuronal connections, and then also changes to our epigenetics with ongoing chronic use of substances. And this can lead to chronic effects on cognition, particularly in the domains of cognitive domains, executive function, memory, and attention. But what do we know about substances and if they can lead to how they impact older adults and if they can lead to cognitive impairment? We know older adults may experience more pronounced acute effects, and that could, for many reasons, including that older adults metabolize medications and substances, including alcohol, more slowly. They may be taking medications that interact with substance or may be at risk of fall. So that acute setting is often higher risk when someone is older than when they were younger. Additionally, as people age, more commonly people have comorbidities, and those comorbidities may interact or be worsened by someone's ongoing substance use. And then in addition, many of us engage in many behaviors to remain safely using substances, and this may be less possible when someone is experiencing challenges to memory, attention, or cognition. But what do we know? Do alcohol and drugs cause dementia? Do they cause cognitive impairment? The vast majority of data comes from alcohol. And what we do know is alcohol can negatively impact memory. Ongoing alcohol use can increase the risk of dementia. We've seen associations in studies with heavy drinking with higher rates of cognitive problems and Alzheimer's dementia. All studies have also seen associations between light to moderate drinking, increasing the risk of mild cognitive impairment progressing to dementia. And if someone already has cognitive impairment, those symptoms can be worsened when someone continues to use alcohol, or if someone has dementia symptoms, they can be worsened when someone's using alcohol. For benzodiazepines, there is an associated higher risk of developing dementia for people who've ever used benzodiazepines as compared to those who've never used. And for tobacco, current smoking is associated with higher risk of developing dementia as compared to those who never smoked or formerly smoked. We have much less evidence related to stimulants, opioids, or cannabis. Both there's a lack of evidence, there's not as much robust literature out there as there is for alcohol in particular, and then some of the evidence is inconsistent. There is some suggestion that chronic use of these substances can result or be associated with cognitive impairment. That said, I'd say the literature is still quite young here, and it's hard to give a conclusive answer. I'm going to turn it over to Dr. DeFries to talk about how do you incorporate substance use assessment for someone with cognitive impairment.
Yeah, so let's talk about how to assess for substance use as part of a greater cognitive health assessment. We're going to start with Dr. Chodas telling us a little bit about the overall cognitive health assessment, and then I'll get into further how you drill down to assess around substance use.
Thanks so much. Yeah, what I'd love to just emphasize today and get us to think about is, as we're working with older patients, how we would know if cognitive impairment and sort of the larger clinical entity of dementia might be at play. And increasingly, we're recognizing the need to be a little more proactive. We could call it screening, we could call it detection, but the idea here is how can we incorporate a cognitive check into a visit with an older adult, just as we might other health screenings like substance use disorder? And is there any reason to change the assessment we're going to do if the person has a co-occurring substance use disorder? So this is one resource for you guys, just one way to frame screening or early detection of dementia or cognitive impairment in an older adult. And we could have a whole other talk on these terms, but I think the broader idea is if I have an older person who has some cognitive symptoms and they're using substances, is it also valuable to screen for these things? And the easiest thing to keep in mind is just an easy process. So Dementia Care has the tools for that, but the brief overview is that you would ask a historical question or note something about their cognitive symptoms. So a brief history could be a screening question like, have you noticed changes in your memory? Or you noticing that they're having cognitive changes. They don't remember things you've talked about in prior visits, or there's noticeable challenges in a conversation or in their self-management. The other is to apply screening tools. And this is where it gets a little broader than how we usually think about screening for cognitive impairment. This approach, called the cognitive health assessment, really looks for functional and cognitive decline. Again, can these things overlap with substance use disorder? Absolutely. But this gives us a little bit of more objective grounding. So you want to use a validated tool to screen for cognition and any impairment there and for function. And so our program, Dementia Care, does give tools for that. For example, something a lot of people have heard of is something called a mini-cog. That's a brief cognitive test, takes about 1 to 2 minutes. And a functional screen, like asking people about their activities of daily living and instrumental activities of daily living and how they do those things. So we have those tools on our program site. And then the other piece is often just a quick check. And again, this is in a screening mode, but a real quick check on, do they have a support system? Who's in their life? Is there a caregiver? Is there a care partner of some sort, like someone who assists them with these daily activities? And can we document that? So that helps us just get some grounding on their cognition, and then we can go on to also, and at the same time or at future visits, assess their substance use. So I'm going to pass it back to Dr. DeFries.
Thanks so much. So older adults, when they experience unhealthy use of substances, they are usually under-identified, underdiagnosed, undertreated in healthcare. So some experts have even called them an invisible population. And that's even though they may be having more frequent healthcare visits. And what are the reasons for that? What makes it so challenging to recognize substance use problems in older adults? Well, it's kind of manifold. Many people think that substance misuse is just a young person's problem. There's stereotypes and bias about older adults, and people with addiction and mental illness. And this is very common, might make it hard to talk about. Stigma and shame, they're common barriers to addiction treatment, and older adults may have grown up in a time when substance use or mental illness received a great deal of stigma. Older adults are less likely to seek care in traditional addiction treatment settings, and it might get harder to diagnose them with unhealthy substance use because things like cognitive impairment, functional impairment, or other medical conditions can obscure or overlap with signs of harmful substance use. And then lastly, clinicians like us can face difficulty applying diagnostic tools to this population, and towards engaging with caregivers can be really challenging. And lastly, we face barriers of time and sometimes lack of knowledge about substance use disorder management. So hopefully we can address some of these today. Patients will present with unhealthy substance use in different ways. Some may present via screening, some may present with signs or symptoms, some might come in with concerns from caregivers or from other providers. And the goal is really that there is no wrong door to address substance use. So this doesn't have to be done in a specialty addiction treatment setting or by a specialist. And so we hope to really equip you with some of the skills today to help, because primary care is a great place for the diagnosis and care of substance use disorders. And you've heard me using the term unhealthy substance use, and that's because substance use occurs on a spectrum, and that spans from abstinence to riskier use, unhealthy use, all the way to substance use disorder when people have problematic patterns of behavior that then lead to negative life consequences. And those are defined by the DSM-5 criteria. And as consumption increases on that left-hand side of the arrow, consequences generally become more severe on that right-hand side of the arrow. And so for older adults or a person with a cognitive disorder, consider how things might shift on this spectrum. The same levels of use, even lower levels, may be riskier. They may have more consequences. And actually, most older adults who misuse substances do not meet full DSM-5 criteria for a specific substance use disorder. They may be engaging in just riskier use of a substance. And consider how substance use may change over an individual's lifetime. And you really can't assess or screen a patient just at one point in their life, but rather really need to rescreen and reassess as they age. A major limitation of our screening approaches is that there isn't a known safer drinking limit, for example, or use limit for patients with cognitive disorders. So here at the example of alcohol, there are US guidelines. They're seen in the blue chart here, as well as the Audit-C screening tool, which is commonly used in clinic-based settings. And these are based on quantities of alcohol that are not necessarily adjusted for patients with dementia. So US guidelines recommend the following drinking limits, and adults over 65 fall into the same category as women here, where no more than 3 drinks a day and no more than 7 drinks per week are recommended. And then drinking over these limits has been found to be connected with health problems like an increased risk of cancer, for example. But for those with dementia, even 1 or 2 drinks may not be safe. So there's really, these guidelines really need to be contextualized to the individual that you're working with. And the recommendation for people with cognitive disorders is that the safest level of alcohol use is none at all. And relying on an older person's report of the frequency and quantity of substance use as the only indicator of problematic use doesn't really give the full picture of the actual consequences of that use. So here's an example. It's the Short Michigan Alcoholism Screening Test geriatric version. And this is just an example of a screener that has been developed and adapted specifically for older adults. It's a brief alcohol misuse screener. And if a client marks 2 or more of these as yes, it suggests a potential alcohol misuse. And this tool has more geriatric focused questions. So I think it's a good example of how some of these screening questions and questions we use with patients can be adapted towards patients with more advanced age. And it includes questions like, when you feel lonely, does having a drink help? And Have you ever increased your drinking after experiencing a loss in your life? So it's designed for a population that drinks less heavily and isn't based on just how much they drink, just on quantity, but really how alcohol is having a role in a different stage of their life where their role and their function is different. Older adults with substance use disorder, they're often underdiagnosed because the DSM-5 criteria, our gold standard tool for diagnosing substance use disorder, does not always capture that well in older adults. So the DSM-5 criteria, they make the SUD diagnosis in the general population, but let's look at some of these criteria to see how well they apply to older adults. So something like tolerance, or the need to use increasing amounts of a substance to obtain the same effects, that's a key diagnostic criterion. But because of the aging process, older adults have a lower tolerance for alcohol or other substances, and they may experience harmful effects at lower amounts of consumption. So tolerance in an older individual does not necessarily translate to being dependent on a substance. Another example is the criterion of failing to fulfill major duties at work, which won't necessarily apply to an older adult who's retired and not working. And then keep in mind that the DSM-5 criteria should be interpreted in this age-appropriate manner. And this chart, for example, does give some guidance on how to adapt these criterion for the older adult. And how will substance use disorder then present in an older adult with cognitive impairment? It's important to understand that the patient's physical health, their overall well-being, is really what is going to help you understand this. And signs of substance use disorder, they might be mistaken for or overlap with symptoms of co-occurring medical or mental health disorders, or just the natural aging process, like common conditions such as sleep problems, chronic pain, difficulty with ADLs, falls, new or exacerbated cognitive impairment, hypertension, or depression. These are all signs of a possible substance use disorder that can certainly be overlapping. And we know that mental health disorders co-occur with substance use disorders. And just like we've talked about assessing for substance use disorder in older adults, it is also recommended alongside that to assess for mental health disorders. And the following screens are often used in this population of older adults: the geriatrics depression screen, which can be a 5-item or 15-item screener, the PHQ-9, which we commonly use, the GAD-7 for anxiety, and the primary care PTSD screen, which is 5 items. And then for older adults with more serious mental illness and cognition issues, just broadly, serious mental illness can affect cognition and function, especially when symptoms, negative more than positive, are present. And it's often attention, memory, and executive function that are more affected. So really making an individual assessment of somebody's cognitive symptoms and strengths will help with making the care plan for them. We're going to talk more about that, about trying to identify what support somebody needs, what strategies specifically help them with retaining information. And whether you're discussing substance use or mental health with a patient, it's important to take a non-stigmatizing approach. So just like with younger adults, these are some techniques, and motivational interviewing strategies are important with older adults as well. So building a welcoming, respectful environment, ensuring people's privacy, which includes asking permission before discussing substance use with patients and their caregivers. You can normalize that you talk to all of your patients about substance use because it affects their overall health. Showing empathy and concern rather than judgment and bias, using open-ended questions and statements can really help with that. And then using clinically accurate, non-stigmatizing terminology, which we'll try to be modeling throughout this presentation, like substance use disorder instead of abuse, or person with a substance use disorder rather than addict or alcoholic, for example. And overall, when you're having this conversation about substance use, your goal is to first assess the patient's understanding of their substance use and insight into its impact on cognition. And this is something you can even ask to an older adult with cognitive impairment. Really first asking them about their perspective, reflecting back what you heard, asking permission to share some information yourself, and then assessing their interest and supports for changing their substance use if they're interested. And the goal is really to provide everybody with universal non-judgmental education about the impacts of substance use on cognition, and then keep the door open for follow-up discussions. We're really not here to try to convince somebody to stop using alcohol or drugs. We're here to try to have this more open conversation with patients and their caregivers. So with that, I'm going to hand it over to Dr. Soren to talk about managing the plan around somebody's substance use. So I will pass it off to her.
Great, thank you. So now that you've started the conversation about substance use in the context of cognitive impairment, what do you do with that? And our recommendation is this approach, starting with that non-judgmental conversation and universal education for everyone, regardless if they're using substances or not. Discuss harm reduction and mitigating risks of ongoing use, offer treatment, and then even if someone's not ready to engage in that discussion or talk about treatment, we still recommend emphasizing other important parts of brain health, including reviewing medications, talking about social networks, and involving caregivers. So first, we recommend that all patients and caregivers should get a universal education about the effects of alcohol and drugs on the brain. As you're talking with someone, you've often already started this conversation as Dr. DeFries modeled, but you can start with, can I share some information about the impact of alcohol on the health of brain and memory? And most often people say yes and want to hear more about the concern they're coming in with today and how their substance use may impact them. Next slide. We recommend everyone have an open discussion about how do you mitigate the risks of ongoing use. We recommend not everyone is ready to stop or is ready to talk about stopping using drugs or alcohol. And that's okay. The goal really is on improving quality of life. It doesn't have to be on complete abstinence, and there needs to be respect and non-judgment for differences in values and goals. Some general practices for harm reduction include, abstinence, especially in the setting of cognitive impairment, is best. Less is better than nothing. So reducing use can be an important goal for someone. Using in the presence of others in the event that there are harms or an overdose that someone is around to support that individual. Also, there's different strategies we recommend for everyone who's using any substance, making sure they have access to food or continuing to eat while they use substances, remain hydrated, and then planning and making sure they have time to sleep and recover from substance use. Using in settings that avoid physical injuries, not driving while consuming substances, and then ensuring both the patient and caregivers have access to naloxone in the event of a potential opioid overdose. For more specific harm reduction practices related to the specific substances, please check out the National Harm Reduction Coalition. We want to highlight that treatment for substance use disorders is very effective and should be offered. There's a perception that maybe older adults aren't interested in treatment or won't benefit from it, and that's not true. Studies really support older adults are both interested and have positive outcomes from treatment. That said, they experience unique barriers, and interventions do need to be adapted to their own individual needs, the same way treatment does for anyone. For older adults, this may or may not include adapting to their physical, cognitive, or other psychosocial needs. Treatment can include both medications and behavioral interventions and harm reduction strategies. We do have FDA-approved medications for opioid use disorder and alcohol use disorder, which I'll talk about more in the next 2 slides. Older adults may experience barriers to coverage of insurance coverage of treatment. For example, Medicare does not cover residential treatment or intensive outpatient treatment. Most Medicare plans will cover medication. And so helping an older adult navigate what their insurance covers and what Medicare does and does not cover can be a barrier and challenge to treatment. That said, we are so glad you are all here to support providing treatment in your clinical care settings and hope that there's no wrong door for treatment when they're seeing you in your clinic. First, I'm going to talk about medications for alcohol use disorder. The bottom line is naltrexone is effective. It helps people reduce cravings, reducing heavy alcohol use, and it's very safe. And so this should be offered to people who are interested in taking medications to reduce their alcohol use or reduce cravings. There are other medications that are both FDA approved and off-label for the treatment of alcohol use disorder that have evidence to support their efficacy. That said, there are more side effects to these, so really you can provide these, but it's always weighing the benefits and risks with the individual patient. However, naltrexone is very well tolerated. For medications for opioid use disorder, for individuals who are experiencing cognitive impairment, They are highly effective medications that reduce all-cause mortality by 50% and therefore should be offered to all people who are interested regardless of cognition because of the significant benefit. Is it methadone or buprenorphine? That really is an individual choice and maybe based on that individual's desire or their comorbidities. Buprenorphine may be preferred because it has less sedating side effects, fewer drug-drug interactions, and can be available in settings outside of methadone clinics or opioid treatment programs. That said, methadone is also very effective, very safe when taken with an experienced clinician. And so if that's what this older adult wants, we recommend also supporting them connecting to a methadone clinic for that treatment. And just a reminder, everyone here who has a DEA license can prescribe buprenorphine. You don't need the X waiver. If you haven't done this already, next time you renew your DEA license, you'll attest to having attended 8 hours of substance use disorder related training. All training that is approved CME counts for that. So this hour counts for some of your training to attest to on your next DEA license. So go ahead and prescribe. Treatment can be both medications and it also can be behavioral treatment. For individuals with cognitive impairment, they may need some adaptations and it depends on that unique individual. Treatment can come in the form of group settings or individual. And for some people, a group setting may be really beneficial to be around peers. For others, the individual conversations that can be more tailored to their needs may be more appropriate. Also, there's more expanded options related to telehealth or Zoom visits that may be helpful for people who have struggled to get to a clinic in person or don't live near a clinic in person. And in some rare settings, there may be the possibility for treatment visits to come to the home. When adapting for cognitive impairment, everyone is different. That said, sometimes adapting these behavioral interventions to be a slower pace, repeating content more frequently, and having a shorter session length can help with supporting that individual really connecting to the treatment. We also recommend for adapting program materials. So some people learn and retain through print or visuals, or having an audio recording they can play later with their child or with their caregiver, or to remind themselves later. Also recognizing you may need to adapt to other needs, whether that's hearing, visual, or physical accommodations. And treatment needs to be relevant. And so if someone is someone later in life or with cognitive impairment may be experiencing different things in their life than younger peer groups. And so finding treatment settings that are able to adapt to more peer-focused, relevant topics is important for this group of individuals. I'll have Dr. Chodos talk about prescription medications.
Thank you. I appreciate that. This is my favorite topic to gripe about a little bit. And I saw one of the questions in the Q&A, and I think I can address some of it here, which is like, what are the recommendations for some of the cognitive changes that we see? And one of the key features of this really actually optimizing brain health opportunity for older adults as we're seeing them age and sort of enter the older years, but also anybody with co-occurring substance use disorder and cognitive symptoms and or a diagnosed cognitive impairment formally or a dementia would really be deprescribing. And so there's a lot of things we do to people that really disadvantages their brain in terms of being able to work with what's there or what's left. So the key things are anything that isn't necessary, whether or not it's really known to have cognitive side effects, should always be removed, because there's a lot of evidence that piling on meds and just the whole phenomena of polypharmacy really sort of drags cognition down, among other things. It affects taste, it affects nutrition, it affects fall risk. So deprescribing in general, when you're coming from the perspective of, do I even know what this medication is for anymore? Do they really need, does this meet their goals and their targets now that they're older or have other comorbidities? And then just the general principle of simplifying things for people with dementia, cognitive impairment, or substance use disorder, I think just helps management overall. So identifying medications with cognitive side effects, though, of course, will give us even more bang for our, per pill, if you will. So we want to look over what's called the Beers criteria. It's a regularly updated, very rigorous resource that really outlines what medications have cognitive side effects. The Beers criteria can be a little overwhelming, and I think the other place to go, it could also be what we call anticholinergic burden calculators. Unfortunately, instead of ABC, that ends up being ACB. But if you just Google ACB calculator, you can find calculators that help you put in a medication and a dose, and it'll give you an overall anticholinergic burden score and how to interpret that. That's because a lot of medications that aren't specifically anticholinergic have cholinergic properties and cognitive side effects as a result. So Benadryl or Paxil, there are lots of things that have some anticholinergic properties, even though they don't fall in that drug class. And the more we can do to dose reduce or remove a medication and substitute it for something else that doesn't have anticholinergic properties, but may be in the same therapeutic group of medications, is doing a big favor for that patient. So as with everything though, older adults are complicated, comorbid, you aren't really sure. You can't just totally slash and burn the medication list entirely. So you may want to go methodically. And again, any dose reduction, schedule reduction, or substitution can help. But in general, if you're like, well, kind of need to leave this medication on for XYZ reason, really thinking with the person and talking to them about the risks and benefits, and potentially stopping or tapering even as a trial. So there are a lot of things people need or think they need, perhaps for mood or other conditions, and we can at least see how they would do without it. This point about really getting patient buy-in, especially, older patients may have been on medications now for a certain medication for 10, 20 years. And it's really going to take some conversation and partnering with them to come to an agreement to change a medication. But then things like, of course, benzos or sleep agents that aren't in the sort of friendlier side in terms of side effect profiles, or less harmful side. I think those are the kind of medications that we want to be more aggressive about, and really talking to people, framing it for them around the fact that now with other conditions, with other symptoms, this is a more concerning and likely harmful medication, and something that we should really work on and deprescribe. The reason I wanted to bring up, what are treatments for cognitive changes for people with SUD versus not? This actually, in a way, is a treatment, really being aggressive and thoughtful about what other medications we're adding to the mix and prescribing for people is actually part of the treatment plan for anyone with cognitive impairment or dementia, is optimizing their prescription medications. We don't, for the underlying diseases that cause cognitive impairment or dementia, we don't necessarily have direct disease modifying treatments for many of those causes. Alzheimer's, the treatment of Alzheimer's disease is starting to change, but that's not really reality now either. It may be in a few years, we may have more of a pipeline to really treat. But other treatments, just to be clear, other than medications, would be sensory input, correcting hearing and vision, encouraging social and physical activity, and other vascular risk factor modification. And if this person's particularly motivated around their brain health, that might be something that factors into the discussion you're having with them about entering treatment for their substance use disorder, or getting different kinds of supports and exploring reducing their use. So now I'm going to pass it back to Dr. Soren to continue the discussion about treatment.
Thank you so much. Along the same lines that Dr. Chodos just shared, an important aspect of both brain health and substance use is your social network. And we know both social isolation can be a contributor to use, and your social network can be either a positive or negative contributor to use as well. Also, your social network could be a positive area for change. And so really talking with that older adult who you're there with about who is around them, what are their social supports, are they isolated, can be an opportunity to talk about how that influences their substance use. For those that are interested, mutual aid groups can be a way of combating isolation, and there are ones specific to older adults. There's one called Seniors in Sobriety, as one way to have a social support that's both related to reducing isolation and building up their changes with substance use. And then we really also want to include, how do you involve caregivers in the discussion when you are talking about substance use? We know anytime that there's an individual who's experiencing cognitive impairment or dementia syndromes, that caregivers need to be a part of the treatment plan. And that's the same for substance use, and this can improve outcomes. We know that for some people, it may be a sensitive topic to talk about substance use around the caregiver. And so we still recommend that you ask permission of that individual to talk about it with the caregiver in the room, because then you can come up with a treatment plan together. Part of this may be assessing the caregiver's role. They may have their own perspective or influence on substance use, both positive and negative. Also including the caregiver and the universal education and any resources you're providing, as they can help support reinforcement of that at home. We also don't want the burden of treatment to fall on the caregiver. So again, having the buy-in of the plan, what is their role, but they shouldn't be the one forcing someone into treatment or having to hold that out if that's not what the individual wants. Really focusing on safety and what's the agreed upon plan. And then recognizing caregivers also are under immense stress. They themselves may be struggling with substance use, depression, other challenges in life. And so caregivers themselves may also need support related to their mental health and substance use. Next slide. So we're going to go over some key points, and then we'll open it up to the question and answer. So we hope today that we've set the framework for how to assess for unhealthy substance use in older adults and discuss how that can worsen cognition. And then how to use a non-stigmatizing approach to focus on substance use and co-occurring mental health disorders that impact overall health and well-being, educating all patients and caregivers about unhealthy substance use, and then providing medication treatment, harm reduction, or adaptations to behavioral treatment that can work with people who are both older, using substances, and may have some cognitive impairment. Thank you all. We do have references in the slides that will be available later. I think we can, our emails are here. We're, always welcome to reach out to us. Here are resources after this, especially want to highlight the substance use warm line that Dr. DeFries works at. A great place for providers to call, to talk about, answer questions about specific patients or about substance use in general. And really just a great resource that's free and a wealth of knowledge, and I encourage you to utilize it. Let's open it up to some questions.
We have two questions, and through our Q&A, the first is related to naloxone, Narcan. The question is, does Narcan have a shelf life?
It does have a expiration date. Often that date is on the conservative end. And so if, for instance, you're in the event that you need to use naloxone that's expired, just use it. Obviously, if you need to use another dose after someone hasn't responded for a couple of minutes, it's okay to use an additional dose, but it does eventually expire. The written date is on the conservative end. You don't have to suddenly replace all your naloxone at that date. That said, having an updated supply, especially in clinics, is really important. If that's all you got and someone's having an overdose, just go ahead and use it.
Yeah, I agree. I think there's an organization called Next Distro that even distributes expired naloxone to different areas via mail, and they have a quote on their website that's "expired naloxone is better than no naloxone." But also just to add that naloxone is now over the counter. Obviously there can be barriers to getting that, including the cost, but you can actually walk into a like Walgreens or CVS and buy naloxone now. You can prescribe it, and you can also stock it in your clinics.
Next question is regarding whether or not there's a national shortage of naltrexone. This individual has had patients who've had trouble getting it due to a shortage.
I have also heard about this national shortage, and I will be honest, I haven't had any barriers. I'm practicing in the state of California with prescribing naltrexone recently. So I don't know. I imagine that this is just impacting different places differently. But I would say check first, because it actually may be available. It's been available for all of my patients in the last couple of months. And I also think that this is a rapidly evolving situation. If you read about it a little bit, there are some things out there on the internet about how it's June 2024, this is going to be corrected and naltrexone is going to be resupplied. So I would just say, don't shy away from prescribing or trying to prescribe naltrexone if you know that that's the preferred medication for a patient, and check and see first before going to an alternative, because it may indeed be available. If it's not available, there are other treatment options that could be considered for alcohol use disorder that can include a acamprosate, topiramate, gabapentin. And for opioid use disorder or methamphetamine use disorder, getting naltrexone for reason, there's also alternatives to consider.
Sorry, our next question is asking whether or not our panel has any opinion on OPV with the non-trade name of nalmefene benefits over Narcan.
Yeah, my understanding of nalmefene is that it's longer acting than naloxone. It's been used in veterinary medicine. Sorry, I'm getting a tickle in my throat, but has not been studied in humans. And I think all of our evidence supports that naloxone is highly effective in reducing opioid overdoses. One of its downside is it does wear off. However, the longer something stays in the system, when they've studied it as compared to higher doses of naloxone or repeat doses of naloxone, it actually can make people sicker, and people may be more likely to use a substance when they're are feeling withdrawal after receiving the opioid reversal agent. So I think in the absence of more data, I'm not 100% supportive, although I definitely support people studying it and seeing if it's one, safe in humans, and then is it achieving our desired effect, which is reversing an overdose and not resulting in extreme opioid withdrawal that people would feel the need to try and use on top of that.
Thank you. We don't currently have any new questions that have shown up in our Q&A. I know that we did receive a number of them through our registration. Trevani, I didn't know if you wanted to share any of those questions for our panel to discuss.
Maybe while Trevani's looking those up, I'll just share another, it's related to the nalmefene question. It's they did an interesting study in New York City. They compared giving people 4 milligrams of intranasal naloxone, which is the regular dose that comes in the pack, versus 8 milligrams, kind of seeing there's sometimes people are worried that fentanyl may be too strong and naloxone's not effective. I'm going to share this report in the chat. And what they found that was 4 milligrams was just as effective, and that 8 milligrams put people into worse withdrawal. That did not, so they recommend really continuing our standard 4 milligram dose. So I'm just sharing that link in the chat for people to check out. Keep using the standard 4 milligram naloxone. Keep it waiting 2 minutes to reassess if someone needs an additional dose. It certainly does wear off after 20 and 30 minutes, and so recommend people engage in ongoing care and transport to the emergency department after receiving naloxone.
Okay, we directed some people to use the Q&A, and so we're waiting for those questions. We did receive a number of questions just related to specific types of substances, for example, methamphetamine, and the impact on cognitive health and aging.
Brenda, I got distracted by the chat. Were you asking about the impact of methamphetamine on aging and cognitive health?
Exactly.
Yeah, it's a great question. There isn't robust evidence to say, will this impact cognitive impairment? What's the direct association? There's some small studies that there's an association with impacts on memory. We certainly know ongoing methamphetamine use is negatively impacts cardiovascular health. And actually most methamphetamine overdoses without opioids are related to cardiovascular health outcomes like stroke or heart attack. And so, and we know, cardiovascular risk factors can contribute to cognitive impairment. So chronic methamphetamine use, I think there's suggestion that can negatively impact cognition and negatively impact cardiovascular health. So certainly something to have in the discussion if you're seeing a patient who is using methamphetamine and having cognitive problems, especially if that's an area that they want to work on, or they want to work on their brain health. Reducing or stopping their methamphetamine use can be an important piece of that. And then we also know, as people age, that they can have more negative effects from their substances. And so Someone may already have cardiovascular risk factors or already have cardiovascular disease, and using methamphetamines in that setting can be higher risk.
Thank you. Triveni, this is for you. Does the warm line have experts on methadone available as well?
Yeah, we can definitely answer questions about methadone. Some of our consultants have worked in opioid treatment programs where methadone is given, and so we are happy to take questions on methadone. We've taken questions from medical directors of methadone clinics all the way to primary care providers of patients who are on methadone. So happy to answer questions about that.
And for our panel, is there any medication assistance for cannabis use?
It's a great question. There are no FDA-approved treatments for cannabis use disorder like there are for opioid use disorder or alcohol use disorder. So it's something that there are studies about different medications, including gabapentin for the treatment of cannabis use disorder. So I have used gabapentin for some patients, as well as adjunctive medications to help people with symptoms of sleep disruption, anxiety, restlessness, sort of symptoms of protracted withdrawal, actually, that people can get when they stop using cannabis abruptly. So I have used those, though there's really no gold standard FDA-approved option.
The next question is regarding Medicare coverage for inpatient treatment. Most of the time, this individual's been told that you need Medicare needs a supplemental to help cover the cost of inpatient treatment.
That is such a good question, and that is certainly a barrier we've seen. There are many different Medicare plans, none of which are the same. That said, I think the vast majority do not cover inpatient residential stays, which is a huge barrier for some people. Getting that residential treatment support is really what they need. I know in California, our Medicaid plan covers residential treatment. So if people do have Medicaid, that is an option, but it's a huge barrier for people whose insurance is Medicare. And as we know, residential can be expensive when paid out of pocket. For many people, intensive outpatient may be more likely to be covered, and in some cases has just as good of evidence as residential programs for those who have housing and have social support. So looking into outpatient options, behavioral interventions, in addition to medication treatment, can be an option as well.
This question is related to nicotine. Is there a risk for a client using a nicotine patch and using nicotine at the same time?
I can start us on this one. The first line approach to treating somebody with a nicotine use disorder is actually combination therapy with a medication, varenicline, plus a nicotine replacement product. These medications can be used to help people reduce smoking in addition to stop smoking completely. So there is totally a role for nicotine replacement therapy for somebody who's still smoking but wants to smoke less. The risk is that somebody's nicotine dependence increases if they're using nicotine products plus smoking. So this really requires closely following up with the patient, talking about how it's going, quantifying how much they're using to make sure that it's actually therapeutic to be using the nicotine replacement in addition to smoking, and making sure it's helping them get to their goal of smoking less or stopping smoking, rather than actually, setting them back by increasing their dependence. So it just really requires defining close follow-up with patients, making sure that you're checking in and talking about how it's going, not just sort of prescribing and then not seeing somebody for several months. And if, as a busy primary care clinician, you don't have time to do the close follow-up that you want, in addition to your visits, you can refer people to quit lines where they can get that kind of counseling over the phone. And quit lines do have a strong evidence base for them. So, for example, where we're located in California, we have the Kick It California line, which is free counseling. And so I'll always give patients that number to follow up in addition to following up with myself and behavioral health team.
Yeah, and just to add to that, often it's asking the patient, what are you getting out of the nicotine product versus smoking? Is your goal to stop smoking or reduce use? Because often people self-titrate both how much nicotine they're using with the nicotine product and how much they inhale from cigarettes or a vape device. And so someone may be using the nicotine product to reduce their smoking. And that is actually, that's good because, with smoking, you're still inhaling those carcinogens. So that may be a small step of progress. And then if someone's goal really is to stop consuming nicotine, to Dr. DeFree's point, really combination with varenicline or Wellbutrin is really important and that are the most effective. And people can still smoke while on varenicline, for instance, and over time, their cravings, their desire to smoke reduces. And so people usually set a goal time to cut back or stop once they're on varenicline, and the nicotine product can help with some of those withdrawal symptoms. So it's fine to use both, unless it's increasing how much you're using. So it's sussing out what they're getting from the nicotine product versus continuing to smoke and what are their goals.
We have another question related to the induction of buprenorphine for older adults, and what age do you define in older? And at what age do you define an older adult?
That sounds like an existential question more than I'm kidding. I'll let Dr. Chodos later define it, because age is a number, and we know, a 70-year-old may have the cognition of a 50-year-old or 40-year-old in some cases, and really age is a number. It's more, I'll leave it to Dr. Chodos to define that. And then I'll go into buprenorphine inductions for older adults.
Yeah, I think unfortunately what we're really interested, right, is physiologic age and if there's sort of a metabolic or physiologic implication of something that we're doing. So if somebody has a really big burden of atherosclerotic disease, or they have sarcopenia, or they have, osteoporosis, that like there's sort of a group of diseases or syndromes, really, multifactorial syndromes that are sort of the domain of geriatrics, and why we would consider someone in need of more of a geriatrics approach. But there isn't a great clinical marker for these things. So it is about knowing your patient and individualizing to some degree. But some things to look for. So we do often focus on the F word, function. So if somebody is starting to need assistance in day-to-day life, that's a good marker that there may be a physical or like an acquired physical or cognitive disability that is a marker of worse physiologic aging. And the other thing just to note, especially when it comes to cognition, it's extremely variable how people age cognitively, and it has a lot to do with early life education and then all the risk factors we accumulate in younger and middle age. But we do know that there are populations with much higher burden and higher probability of aging, physiologically aging more poorly from a cognitive standpoint. And some of those populations are people who are experiencing homelessness, people who have had involvement with the criminal justice system, and just people who've had low quality education over the education that they could get. And that's a hard thing to measure. So a lot of times we're just ballparking it, but there's some populations that you might want to screen for some of these things like cognitive impairment at earlier ages, like 50 or 55. So I'll pass it off to say how you think about that when you're thinking about treatments for substance use disorders.
Yeah, for buprenorphine, I'd say there's two modifications I might consider. For buprenorphine dose, first, most of that is related to someone's tolerance and then how their body responds to the medication. So it depends on what opioid that individual is using. Is it a high potency opioid like fentanyl, or is it something like intermittent opioid pills that have a much lower morphine equivalent? And then for older adults, you may want to start at a lower dose and titrate up more slowly because they maybe have experienced more side effects from it. And in buprenorphine, the most common are it can be kind of activating. Some people get sedated from it, some nausea, headaches. And so you may consider titrating up the dose more slowly. That said, I wouldn't change too much of the induction. Really, it's letting them drive it based on their symptoms. The other thing I would consider though is what environment are they going to do it in? What supports do they have? How frequently you may see them, maybe more frequent or with telehealth check-ins as someone's trying to start buprenorphine. Because if they're on their own or already having trouble with managing other medications, you may need a more supportive setting. And for some people that may be telehealth visits, for other people it may be a withdrawal management or detox program that can support them, or it may be getting a caregiver, family member, or other clinician that or caseworker that's working with that individual to kind of support them during the early phase of buprenorphine treatment. Thank you for the question.
I think we have officially run out of time. I want to thank Doctors Anna Chodos, Christy Soren, and Trevani DeFries for an incredible presentation and for fielding so many questions for all of us today. The evaluation for today's webinar is on our screen. We would love it if you could take some time to just let us know what you think. We also are always interested in new topics you would love to see us to cover. And we wish everyone an amazing rest of your day. Once our recording is available, we will be providing that to all registered participants. And again, feel free to reach out if you have any questions. I'm going to put our substance use hormone information in the chat in just a moment.
Thank you all.
Thank you. Have a great day.
Thank you. And thanks, Brenda, for moderating.